Good morning, everyone. My name is Ophira Ginsberg, and I'm the Senior Scientific Advisor for Clinical Research at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control Seminar Series. The seminar features talks by researchers and cancer control experts working in global oncology and provides opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. Now, I'm really delighted today to welcome Dr. Tran Thanh Huong, Dr. PhuongThao Le, and Ms. Carolyn Taylor to the center this morning. Dr. Huong is the Vice Director of the Vietnam National Cancer Institute and Chair of the Department of Bioethics and Health Psychology at Hanoi Medical University. She has extensive experience in research and practice addressing risk factors for cancer and other non-communicable diseases. Dr. Le is an assistant professor in the Department of Community Health Sciences at the Boston University School of Public Health. Her research focuses on examining mental health and sociocultural issues to inform the design, implementation, and evaluation of health programs and policies among marginalized populations globally. Ms. Taylor is the founder and executive director of Global Focus on Cancer and a global advocate and leader in support of cancer care, committed to addressing disparities and improving outcomes for people with cancer in low-resource settings. She is deeply involved in global research and policy and serves in various roles for the Global Oncology Commissions, initiatives, and journals. Together, they work to develop and pilot the Stronger Together program, designed to promote one-on-one peer support for newly diagnosed cancer patients in low-resource settings. In this seminar, they'll provide an overview of the challenges and unmet needs for psychosocial support in Vietnam's cancer system, review the design and results of the pilot study in 4 hospitals in Vietnam, and present the Stronger Together Toolkit, a comprehensive resource designed to scale and replicate the Stronger Together program in diverse settings. But before handing the session over to our esteemed speakers, I'd like to review a few logistics. First, please save your questions for the designated Q&A time immediately following the presentation. You can type your question in the chat box or use the raise hand feature. Second, please note that today's presentation is being recorded and will be available on our events website, and you can see that here. And finally, you'll also find information about future seminars on our events website and by connecting with us on LinkedIn. As a disclaimer, please note that the views expressed in the following presentation are those of the speakers and do not necessarily reflect those of the National Cancer Institute, National Institutes of Health, the Department of Health and Human Services, or the US government. The other disclaimer is that I'm pleased to say I was involved in this research, and it's really a special treat for me to moderate today. Now we'll begin our presentation. Welcome, Dr. Huong, Dr. Le, and Ms. Taylor.
Thank you again, Ophira, for the introduction, and really we're so grateful to the NCI for to share this NCI-funded work, which was supported through a supplemental grant, and with deep thanks for their continued support and collaboration. So good day to everyone. Thank you again for this opportunity to present. It's also an especially meaningful day for me, as May 8th is World Ovarian Cancer Awareness Day. And it's a day that resonates personally with me and with so many others affected by this disease. Again, I'm Carolyn Taylor. I'm the founder and executive director of Global Focus on Cancer. So I never set out to work in cancer advocacy. And for decades, I worked as a commercial advertising photographer. In 2006, I was diagnosed with ovarian and endometrial cancers. I was fortunate to be diagnosed early, treated promptly, and to have access to care, support, and options that many people don't. That experience left me with both gratitude and a deep sense of responsibility. In 2010, I received 10 international flights through a British Airways contest. My proposal was simple: to use photography to show that regardless of race, religion, nationality, economic status, cancer has no borders. Over the course of a year, I visited 14 countries where I met more than 200 people whose lives were shaped not only by cancer itself, but by the systems around it, whether care was available, affordable, respectful, and responsive. Through their stories, I came to understand that personal lived experience is a form of evidence, revealing what formal systems often miss: delayed diagnosis, stigma, financial catastrophe, untreated pain, and emotional distress. What began as a creative project quickly became something more. Global Focus on Cancer, the NGO I founded and lead, was born from the recognition that lived experience is this vital form of data into how systems succeed and where they fall short. Our mission was clear: to develop culturally grounded, people-centered models that could be adapted and integrated into health systems, particularly in resource-challenged settings. More than 70% of all cancer deaths occur in low and middle income countries, yet while momentum has grown around translating clinical treatment, the profound emotional, informational, and social needs of people with cancer remains critically underserved. The need for psychosocial support is well established, but scalable, practical models for resource-limited settings are still quite rare. GFC began working with Professor Huong and partners in Vietnam in 2012 to support the development of clinician-led supportive care within the health system. In between 2013 and 2016, we worked collaboratively to strengthen psychosocial support services, laying the foundation for something more expansive. And during this period, Vietnam's national investment in early breast cancer detection had really begun to show results. More women were being diagnosed earlier and living longer. At the same time, informal peer support groups like the KC Breast Cancer Club that you see here were emerging organically across the country. These grassroots efforts reflected a clear need. Women were seeking connection, understanding, and emotional support from others who had been there. But these peer groups with deeply meaningful, though they were not integrated into care pathways. They lacked standardized training, clinical coordination, and sustained support, which limited their reach and their impact. But this really signaled to us a powerful opportunity to meet a growing unmet need with a model that could bridge between health system and community connection. So this led me to reflect on my own cancer experience as a participant in the Woman to Woman program, which is a peer-to-peer support initiative launched at the Mount Sinai Hospital in New York in 2004, which uses trained and monitored volunteers with lived experience of gynecologic cancers to support newly diagnosed women. The model showed me what was possible, but it couldn't simply be copied and pasted. We knew that if peer support was to work in Vietnam, it had to be developed with Vietnamese stakeholders, not just brought in from the outside. So together with Professor Huong, Rachel Justice, who was the lead of the Woman to Woman program, Dr. Lay, various researchers, clinicians, individuals with lived experience, and health system partners, we looked to create this new model. So Stronger Together was not just born from best practices, but from deep partnership, shaped by local context, guided by community insight, and aligned with Vietnam's health system from the start. And it launched in 2017 as this truly collaborative, culturally grounded response to an urgent need. The Stronger Together program is a peer-to-peer support program that trains, supervises, and integrates people with lived experience of cancer into supportive care pathways for newly diagnosed cancer patients. The program was designed to meet core goals, to provide emotional and navigational support, provide information to patients and their families, decrease distress, increase adherence to treatment, and build a sense of community and purpose among the cancer survivor population. It's not a standalone initiative. It's system integrated, culturally grounded, and sustainably focused from the outset. The program is either embedded within hospital services or maintains strong clinical affiliations to ensure alignment with patient care. People with lived experience of cancer are identified, screened, and trained to meet competencies by a program coordinator, gaining practical skills to serve as peer mentors. The program coordinator also meets rigorous training and competency standards. They work closely with the medical team to oversee the program, train mentors, and then thoughtfully match those mentors to newly diagnosed patients based as closely as possible on cancer type, stage, age, language, culture, and patient preference. The structure ensures that support is not only available, but personalized, responsive, and integrated into cancer care experience. Now I'll turn it over to Professor Huong to speak to the broader psychosocial care context in Vietnam. Then Dr. Lay will follow, who will share findings from the NCI-funded trial. And then I'll return to talk about the toolkit. So, Professor Huong?
Good evening, good morning, everyone. My name is Huong from the Vietnam National Cancer Institute and Hanoi Medical University. Firstly, I would like to thank the NCI and also thank to all the colleagues for me to have the chance for present today. And thank Carolyn for the always support for the Vietnamese cancer patient in Vietnam. And my presentation to show about why we develop the peer and to peer support program for the woman cancer in Vietnam. And everyone should know that cancer is the physical disease with the leading rate of psychosocial problem is ranging from 29 to 47% depend on the study. And also psychosocial care is an important part of the comprehensive care in cancer. And in Vietnam, next slide, please. And in Vietnam, about the cancer network in Vietnam, we have 8 oncology hospital, 83 department or center belong to the general hospital or specialized hospital. And 90% of the province in Vietnam have a cancer department. And we have the National Cancer Program started in 2008, but we are lacking and limitation of the human resource and also the budget for the psychosocial support for the cancer patient. And report, next slide, please. And a report from the Global Can 2023 to show us every year the Vietnam have 180,000 new cancer case, and the number of deaths is 120,000. And now we have more than 400,000 people living together with the cancer. And most of the common cancer in women in Vietnam is breast cancer, colorectal cancer, stomach cancer. And the study from our team to show us 54.7% of the cancer patient had distress and 46% had depression. And the rate of the anxiety from the cancer patient is ranging from the 28 to 43% depending on the study. And nearly the 60% of the cancer patient have a sleeping disturbance. And in which we 4.9% of the cancer patient got the severe distress and 4.6% of the patient got the severe depression, and that means that they have the high risk of the suicide. Next slide, please. We also have one study to identify the human resource, the healthcare system of the oncology, in which we identify the human resource in oncology. Now, compared to the other country, and for the oncology surgeon or medical oncologist, we have similar with the ASEAN country. But in this slide, you can see that the number of the palliative care staff or psychology and psychiatry for 100,000 population is only 0.1, and the number of the psychology and psychiatry per 1,000 cancer patient is only 0.4. That is a very limitation of the human resource to support the psychosocial for the cancer patient in Vietnam. And for the cancer in women in Vietnam, and nearly of the 20% of the new case as a breast and gynecology cancer, and they need the more psychology and emotional support. Many of the women cancer patients, they concern about the what's the impact or the disease impact to the family, and they also got the challenge in the spousal relationship, and sometimes they also got the social stigma and discrimination. One study from our team study in 418 cancer patients at the Vietnam National Cancer Hospital, and the 2 psychological states of shock and denial and anger are 2 factors that statistically significant to demand for psychological care. And in this graphs, you can see that they need the psychological counseling and the consultation the rate is around 70%. They also need the psychological therapy. It's around 50%, and they need also the consultation on the self-care department. However, in some of our study, also to show that the barrier to seeking the mental health care in Vietnam is also because of the stigma and also because of the culture in of the Vietnam, and the barrier to seeking the mental health care from the cancer patient, including that they not knowing where to get the mental health support. They also wanted to manage the mental health independently because of the stigma, and they thinking that mental health in region on it's their womb. It's also related to the knowledge of the mental health, and also the 61% of the cancer patient they denying the mental health concern. We also know that the consequence of the unmet psychosocial problem on the cancer treatment, it can to short-term the consequence or the long-term the consequence. The short-term consequence can be the increasing the physical symptom like pain, insomnia, or nausea, or decrease ability to make the decision, or they can take the harmful behavior like they can be smoking, drinking, alcohol, or they can use a sedative, and let the support the relationship, and for long-term consequence, the patient can have the low satisfaction of the treatment, and also the influence to the adherence of the treatment, so that and some of the patient they can have a suicidal ideation, suicide attempt, and suicide. And in fact, in my hospital, in the National Cancer Hospital, we also show that we also had some of the cancer patients, they got the suicide, especially in the pandemic area, pandemic period. Next slide, please. And that is why we propose some solution for the psychosocial needs among the cancer patient, and some is a psychology, and we involving the social work and the peer support is also in the some of the study, and the evidence by propose the solution for the psychosocial needs identified from the many the paper in Vietnam. And in our normally in the cancer hospital in Vietnam and especially in the Vietnam National Cancer Hospital, we have a psychiatrist, we have a nurse, we have a psychology, and we have a social worker. So that's what we are thinking about how to and also the peer support to develop some kind of the model to support upon the psychosocial care for the cancer patient. And even that's now we also have some programs, a navigation program, where the programs that we integrate the nurse, the psychologist, psychiatrist to support for the woman's cancer. But we are lacking of the program, but the patient to support for the patient. And we also realize that in Vietnam, when the patient they got the diagnosis of the cancer, and the first person that they contact and that they want to communicate is the patient they have the experience from the diagnosis and to until the treatment, and that is why I think that's we think that's the peer-to-peer support program can be very helpful for the cancer patient, especially for the woman cancer. And now we have some kind of the psychosocial support for women living with the cancer in Vietnam. It's firstly the communication activity, and it can be implemented in the hospital-based or community-based. We also have some kind of the psycho-oncology care, but it's only implemented at the Vietnam National Cancer Hospital because we have it's a big cancer hospital. And we also have some kinds of social support program like information support, financial support, or medicine support, especially through to the Bright Future Fund. And also we have the peer-to-peer support. That's Carolyn and PT also present today. And for the last slides, I would like to introduce about the KC Club. It's the network for the breast cancer patient in Vietnam, and I think it's also the reasons why Carolyn and me and PT want to develop the peer-to-peer support for them. And this club, they established in 2014 and as a nationwide, and they is a network of the breast cancer patient in the whole of Vietnam. But in Vietnam, from the regulation, we cannot have the cancer patient association. And that is why we are knowing we organize many activity for the cancer patient, but we only call that is the club and not the cancer patient association. And now the network of the KC, they have more than 10,000 breast cancer members, and they have a very close collaboration with the doctor, with the Private Future Foundation in the awareness for breast cancer, and also they usually to talk as a patient club and to support for the new cancer patient. And this is the last my slide to talk about why we developed the peer-to-peer support program. Now we would like to invite the PT to present about the result of our study. Thank you.
Thank you so much, Dr. Huong and Carolyn and Dr. Ginsberg for introducing, setting the context. My name is PhuongThao Lê. I go by PT at Boston University School of Public Health. And I was very fortunate to know of Carolyn and then her work in Vietnam, and then through her, Dr. Huong and the KC clubs, etc. So I was have been involved in the research side of things. So I'm going to talk a little bit about the adaptation process and then the trial that we implemented. For the adaptation, as Carolyn mentioned before, we adapted the program from the woman-to-woman program, which originated at Mount Sinai Hospital in New York, but we wanted to adapt it to the Vietnam cancer care context, as well as some of the cultural, environmental characteristics of the local setting. So for the woman-to-woman program, it was for gynecological cancer patients, but for Stronger Together, we realized that there were some adaptations that had to be made. So we expanded it to include breast cancer patients as well, survivors, because of the high breast cancer prevalence in the country. In terms of the literacy level, a lot of the program materials we were able to just translate directly and provide those as written materials because of the high literacy levels in Vietnam. Because of the hierarchical health system and the national regulations and policies, we wanted to have something that is integrated into the current healthcare system. So working with the clinical leadership within the clinical leadership structures in Vietnam. For woman-to-woman is the one-on-one individual training, but for the Vietnam collectivist culture, we found that people really liked being together, supporting each other. So we modified the trainings for the peer mentors to be group-based. And then we, in our effort to integrate it, we sought the engagement and championship of the clinicians within these hospitals. Next slide, please. So some of what I am talking here, and as well as in our process of adaptation, you can find in the paper that we published in Supportive Care in cancer. What we used is a cultural adaptation framework by Castro Guerrera and Martinez, thinking about these cultural characteristics that I mentioned. So the framework breaks down into 3 domains, and then thinking about the types of adaptations that we had to make to the model. So we thought about the content. We didn't have to make a lot of modifications to the content, but we had to think about how we modified and localize some of the forms of delivery. So again, expanding it from gynecological cancers only to breast and gyne cancers, the group-based training, and also integrating it into the hospitals and having the program coordinators be part of the healthcare system that is already in existence there. Next slide. So after the adaptation process, we had the opportunity to apply for an administrative supplement, part of the P30 Cancer Center grant of NYU Langone Health. So the pilot study had 2 aims. Basically, we quantitative aim in aim 1 and the qualitative aim in aim 2. We wanted to evaluate in terms of the comparing 2 groups of people, those who were matched up with a peer mentor and those who were going on as with usual care, so care as usual. And we measured it at 3 time points. I apologize, 4 time points, 0, 2, 4, and 6 months on several mental and behavioral health questionnaires, including depression, anxiety, stress, self-efficacy, quality of life, and social support. I'm going to be going over only the mental health related questionnaires today. And then the aim 2 is that we wanted to conduct an evaluation from an implementation science perspective of the acceptability, appropriateness, and feasibility of the program, the intervention model, by conducting focus group discussions and in-depth interviews. We piloted among 4 hospitals in Vietnam: the K National Cancer Hospital in Hanoi, the Hue Central Hospital, so the oncology center of Hue Central Hospital in Hue, at the Women's Hospital in Ho Chi Minh City, and at Cần Thơ Oncology Hospital in Cần Thơ, which is part of the Mekong Delta in the southern part of Vietnam. In terms of the study design, we recruited people. Eligibility criteria included 25 years and over. They had to have been recently diagnosed, so less than 3 months of having a diagnosis of breast or gynecologic cancer. And they also had to have scored less than a 7 on the NCCN distress thermometer, which is a scale from 0 to 10, like assessing the degree of distress that they feel at the moment. And then we asked them to select themselves into 2 groups. One group, if they wanted to be matched with a peer mentor, a trained peer mentor, so they would go into the arm 1, the peer-to-peer psychosocial support group, and the other group, they said no, they don't have the need for peer support. And then the qualitative aims, we conducted, go back, Carolyn, please. We conducted the in-depth interviews and the focus group discussions, so at the IDIs and the FGDs, the IDIs at 4 and 8 months, and then the FGDs with the cancer patients, the program participants at month 6. Next slide. These are some of the sample characteristics. So this is our table 1 in terms of the distribution of the program participants at the 4 sites. It was, we had a total of 186 people in the 2 arms, 91 in the intervention arm and 95 in the usual care groups. Many in Hanoi and in Hue, we had many people as well as PhuongThao in Ho Chi Minh City at Vu Women's Hospital, because the program, the intervention, the study was conducted during the height of the pandemic. So they were not able to recruit as many people to participate in the program, but they still were able to recruit a total of 28 people. So that's the testament to the effort of the staff there. In terms of the cancer types, more than 80% of our sample had breast cancer. So that's something to consider, and I'll go over a little bit about the breast cancer specific subsample in our population. In our sample. In terms of cancer stages, the majority were diagnosed at stage 2, so more than around 50%, and then around 18, ranging from 16 to 20% diagnosing at stage 1. So the majority of our sample, again, are diagnosed at stages 1 and 2. In other socio-demographic characteristics, the sample is at the mean age of around 49. Many of them, the majority of them, had secondary, high school, or postgraduate education. Around 79 to 80% were married, and the average score 11 in the mentee group and 4.37 in the usual care group. And just for background, the usual cutoff for the NCCN distress thermometer is around 4 to 5. As you know, having scores higher than that, meaning that you have moderately or severe distress. So I'll go over some of the findings that we have. So in terms of depression, so we measure depression, anxiety, and stress using what's called the DAS-21 Depression, Anxiety, and Stress Scale with 21 items, and each of the subscale had 7 items. So for depression, in the total group, you can see that with the mentees with the solid line, you can see a downward trend as the months progressed. And the usual care group, the dotted lines are also a downward trend, but there is a slight increase at 2 months, right? So that's the depression, and then we have the total sample as well as the breast cancer only sample. And again, breast cancer, 80% of our sample were breast cancer patients. So this is for depression. This is for anxiety. So in general, you also see the downward trend. For stress as well, we also measured quality of life and using the SF-12, the short form 12 questionnaire. And for the SF-12, they had 2 components, the mental health component score, and then the physical health component score. So these are the illustrations in terms of the scores that the participants reported with the mental health score, the physical health score, the total sample, and the breast cancer only sample. So we can see as time progressed, there were improvements in the quality of life, mental health, and physical health scores, but it does look like the mentee group had bigger improvements, better improvements in terms of these scores. We also did, next slide. So we also did a difference analysis between the baseline and the 6-month scores for these measures, comparing, the pre and post intervention basically, and comparing between the control and the intervention group. So for the total sample, the DAS-21 scores, we did see improvements as you saw in the graphs, but neither none of the subscales of depression, anxiety, and stress achieve statistical significance. However, in the mental health component score of the quality of life measure, we did see a significant improvement in the control group, in the intervention group compared to the control group. There. Next slide, please. And the difference analysis, oh no, yeah, okay. So, and we also did a supplemental analysis where we did the DID analysis only for the breast cancer only patients. And here we see statistical improvements in the depression and stress scores. As I mentioned earlier, we also did the qualitative evaluation AIM, and this is ongoing. So, but I wanted to present some of the preliminary findings that we have. So we have three themes that came out of the qualitative evaluation. Theme one is that regarding acceptability. So it had very high acceptability. It is meeting the psychosocial needs of newly diagnosed cancer patients. Theme two was the impact of COVID on the feasibility of implementing the intervention. And theme three, cross-cutting across acceptability and feasibility, the need to recruit, train, and support mentors throughout the process. So in terms of theme one, one sample quote that we have is here, where the healthcare worker from Hue Central Hospital acknowledged that many patients, when they are newly diagnosed, have issues such as anxiety and fear, and because of the hierarchical structure in Vietnam, so there's a distance, they cannot get a lot of time with their doctors. So having such a peer mentorship program is creative and useful, is humane. One of the words that came up time and time again in our analysis is that, and that they find it more useful and more effective than the spontaneous cancer peer support groups that are happening. In terms of theme two, we started the trial actually in March 2020 as COVID was hitting the world. And then there was a lag in Vietnam where it was hitting very heavily in Ho Chi Minh City in particular later in 2020. So we had to actually adapt the intervention. So the intention was that the peer mentors would meet one-on-one and like in person. But we had to switch because of COVID to phone calls or virtual meetings with the interactions between the mentors and the mentees. So it limited their ability to help the mentees, not having that in-person interactions. For the hospital staff, they really tried their best to overcome the challenges in terms of logistics, balancing the workload in terms of COVID and the pandemic prevention control efforts with implementing a research study at the same time. And for theme three, they recognized a lot of the hospital workers as well as the peer mentors. They wanted more additional refresher trainings because they found that the communication skills that they received, the training on those were very beneficial. So coming up with supportive supervision structures for the program to continue as the program gets implemented would be helpful. So in conclusion, Stronger Together is a low-cost, low-intensity peer mentoring model that could reduce the negative mental health symptoms among newly diagnosed patients in Vietnam, and we believe in other places in the world too that Carolyn is going to be talking about. And the effect, we believe, is likely the greatest in the initial stages. As you can see, there's a big dive or improvement in mental health symptoms from 0 to 2 months. So after diagnosis. And there is a very high acceptability and feasibility, but it can be strengthened by making sure that the roles and responsibilities of the peer mentors, of the program coordinators are clear. And there are reinforcements in the training skills and the supportive supervision of the mentors throughout the program.
Thank you so much, PT. And again, the findings really reinforce what we witnessed firsthand during implementation, right? That peer support, when thoughtfully designed and meaningfully integrated, can really transform the experience of care. And while our partners in Vietnam were doing this Herculean feat of running the study during the COVID-19 pandemic, at GFC, we really, as PT was just alluding to, we began to ask ourselves, like, how do we move from a single successful model to something broader? How do we support others to adapt this approach in their own systems and with their own strengths, cultures, and constraints? And that I'm pleased to share how the Stronger Together Toolkit model has now evolved into an implementation ready toolkit. So, and the toolkit offers more than a step-by-step guide. It's really a flexible, scalable framework that supports countries and organizations in adapting peer support into their own settings. It brings together everything we've learned about training, integration, sustainability, policy alignment into one resource that's aimed at turning, effective practice into lasting system change. So the toolkit's really based on 3 core modules, the institutional and organizational level, focusing on system readiness, on program structure, stakeholder engagement, M&E, sustainability, whether the model is going to be within a hospital or NGO-based or hybrid care model. Then for the program coordinator, the module outlines their core roles, responsibilities, and competencies of whoever the person overseeing the implementation might be, whether it's a nurse, a doctor, a social worker, or a trained community staff, or a combination, which is what we used in Vietnam at the different sites. It includes planning tools, supervision, guidance, and templates for integration into clinical workflows. Module 3 looks at comprehensive training for peer mentors, for people with lived experience of cancer, including, we talk a lot about confidentiality, communication, psychosocial issues, coping strategies, how to set boundaries, medical advice versus medical information. We do a lot of role play. It's very practical, and it's also culturally and resource adaptable. The toolkit is structured to support the full arc of program design and implementation, includes training materials for the coordinators and peer mentor resources for planning and evaluation, activities that help programs embed the support into existing workflows, also build sustainability, and from the start, equipping programs with the tools that they need for long-term adaptation, evaluation, and integration into national strategies. So it's structured not just around theory, but really practical resources to support real-world implementation. It includes videos, training slides, worksheets, and activities that are designed to guide programs through every phase, from defining the intervention to assessing readiness and building sustainability. There's across all modules, there's a strong focus on building competencies, ensuring quality, integrity, and cultural relevance as programs grow. And we're really excited to expand the toolkit further. We just received funding to develop a 4th module, really that's focused on advocacy, policy, and health system strengthening. It reflects, the core truth that we've seen across every setting, that without policy and system alignment, even the most effective programs risk remaining temporary, disconnected, or dependent on champions. This model will really support implementing teams and advocating for integration into national cancer strategies, aligning with universal health goals, and building durable institutional support. It's a real deliberate shift that we're making from just merely program replication to system transformation. And building on the experience in Vietnam, we're now looking at adapting it to multiple settings. So in the United States, the model is supporting breast and gynecologic cancer patients outside of New York City, in Rye, New York, in a very high resource setting, actually. In Rwanda and Ethiopia, we received funding to trial among breast cancer patients in both countries. Malaysia is the Breast Cancer Welfare Association is building on, they've had a very long-standing reach to recovery model, but they're going to be taking on the Stronger Together model because it provides more resources for them. Again, we're partnering with Western Sydney University to adapt the model to inform a patient navigation program among Chinese and Vietnamese immigrant populations there. And we have prospective new members coming online shortly as well. And then to support sustainability and really shared learning across countries, we've established a learning collaborative. It's designed to share strategies for success, encourage local ownership, foster innovation and emotional support among implementing teams. The goal is not just to replicate the model, but to build a community of practice, really strengthening system capacity, improving individual outcomes, and forming broader policy integration. And we'll be centralizing resources. We'll have webinars, shared tools, and publications, really looking to ensure that the lessons that are learned in one context can support and strengthen programs in others. And the toolkit's designed not just for one or we've only trialed with women's cancers at this point, but we're really excited to look how it would cross over additional cancers or even additional disease platforms. We really feel that the model is quite strong that way. And by its very nature, using trained volunteers with lived experience as facilitators, the model remains a relatively low investment, high impact intervention that's evidence-based, culturally adaptable, and people-centered in its very design. So at its core, Stronger Together, it's more than a technical package. It's a platform for equitable knowledge exchange and ensures that models developed in and for low resource settings can inform global practice. It centers the value of lived experience. It honors cultural context, builds essential bridges for community-based support and clinical care, because ultimately, equity in cancer care isn't just about access to treatment. It's about treating the whole person, not just the disease. It's about ensuring that the emotional, social, and human dimensions of care are available to everyone, not just some. And with that, we say thank you so very much. And I'm happy to answer your questions.
Wow. Thank you so much, all three, for an absolutely stellar presentation. I have to say we'll open the session for questions. And I'm a little choked up, partly because I've been following this along for years. We invite you to turn on your cameras, use the chat feature, raise hand feature if you have questions. We've got almost 15 minutes, which is terrific. But I am going to take the liberty, the prerogative, to ask the first question, just as someone who's worked spent a lot of time in Vietnam, as I think a lot of you know, since 2004. I'm really inspired by the progress that's been made in your country, Professor Huong. Having worked with you over the years in your various leadership roles and seeing the degree to which not only that capacity has been built now from early detection using navigation, et cetera, for good, excellent quality care that really reaches the whole population. But psychosocial care was relatively new, as I recall, and it reminds me that sometimes, we need to do a lot of work around socializing the concepts around psychosocial care for particular cultural environments, et cetera. I'm going to start by asking you, Professor Huong, what is the most, take-home message that you have, or is there something that surprised you particularly as you went about doing this work? Thanks.
Thanks, Ophira, for the very interesting question. And I think that's from the what we learn and what we do, and also from our study, and I think that's the key message is the psychosocial support for cancer patients is very, very important. besides the medicine treatment. Maybe in Vietnam, before that is very poor. So that the doctor and the government also only the concern about how to treat the patient. But now the economics are growing, and also the people have the knowledge is increasing, and now and also the require from the patient. And now so we like Carolyn said that we don't treat the disease, we treat the person. So that I think that's the psychosocial support for the cancer patient is very, very important. But in low resource setting, normally they deny about that. So that we must to support when we treat for the cancer patient.
Thank you so much. And while I'm waiting for other questions to pop up, I'm just going to make a comment, if you don't mind, and I'd like to hear from you, PT, about this, and we'll be on a first name basis now. I'm wearing two hats here, but as we went about drafting this protocol, and it just shows you what incredible reach that a modest amount of funding. This was a supplemental award to the main cancer center grant for, in this case, NYU Perlmutter Cancer Center from the NCI, that took a project, a piece of work that was already happening in US, but never evaluated. It had not undergone research, as I recall. Carolyn, you might speak to that at Mount Sinai Hospital as a recipient of that care, actually, participant rather. And so here we have this study with, high quality quantitative and qualitative and quantitative findings, a toolkit that's come out of it, and now plans to advance some adaptation in different settings, including here in the US. So I think that's quite remarkable. PT, did you find anything unusual about that process, or explaining it to your colleagues at Boston University or NYU when you were here? Thank you.
No, I think, thank you so much, Sophia, for the question. I totally agree. This is, this is one of the opportunities that came at us, and we took it, because of the funding call that the original administrative supplement requested proposals that included global population, so that we can draw lessons from our global work and inform the work in the United States. So that was that's why it was able to come under the cancer, the P30 mechanism, administrative supplement mechanism. And with our work, before the pilot study we did, as Carolyn mentioned, started in 2017, right? So it's 3-4 years even before that, and more so, the Carolyn has already laid the groundwork on the ground with the support of Bright Future Foundation, Bright Future Fund that Dr. Huong also directs, and the support from the hungry of the cancer survivors to do something that is, more systematic, and with the guidance of science, evidence, public health research evidence in that, and that's why you see that there are a lot of people who have come to us, to Carolyn in particular, to replicate this model in other settings, because it is relatively low cost, low investment, and it capitalizes on the strength that are already there in the community, in the local context.
Thank you so much. I encourage people to raise their hands. I don't see hands raised, but I do see one question that I might just read, unless Annette, you wish to unmute and ask about the patients, the women who participated being self-selected, usual versus peer support. I can speak that part. It was not considered appropriate for the ethical review within Vietnam to have a randomized controlled study. But do you address, Carolyn, perhaps, if the baseline?
Sophia, there are several questions on chat.
Oh, I can't see that. I can't see Annette's question. Sorry. Thank you. Annette, would you like to ask yours? It was about the baseline scores of the two groups. Anything you want to add to that question? And then I'll look for the other questions. Thank you. Maybe she doesn't want to unmute.
I know. I'm
Go ahead.
just having a little trouble unmuting. Thanks. I was wondering if you looked at the baseline scores of the two groups and whether they were the same, or if patients or participants, I should say, self-selected, if you will, based on their level of distress. So in other words, did the more distressed patients self-select into the peer support group?
Yeah, so we did look at the baseline scores in all of the measures between the two groups, and there were no statistical significance between the two groups. So as I showed the statistics for the distress thermometer, but we did examine in the other measures too. So even though it was not a randomized controlled study, and they self-selected, but they basically distributed themselves quite evenly in terms of the measured variables.
Great, thank you.
I mean, can I just add, I think we also thought that, you know, the women that selected, they felt they had a strong social support network to start. That maybe they had more support, and didn't feel like they needed the one-on-one. But then we did see that their distress, rose as in the first 2 months. So it would be interesting to see if they had a peer support. Would it be, in the future, would they opt in? It's not something we ask them though, and if they had interaction with each other in that context too.
Wonderful. Is it Cindy was next, I believe?
Yes, this is a wonderful program, and thank you for sharing. I am not in this field. I just came on board because I was interested in understanding what's been done for care in Vietnam. Caroline, and maybe Dr. Huong, do you guys have these programs for other types of cancers, say for prostate cancer, for the pediatric population? And then the other question is, in terms of the Vietnam, national cancer care, is there a program for caregivers? Caregiver support also contributes a lot to the the patient support system, or is that looked at as part of your research in terms of how much caregiving support they have in your study, Dr. Tao, with understanding, does that contribute to the improvement in their mental health, or improvement in their psychosocial care? Because that's a component that would, if you teach them how to better communicate how they feel to their caregivers, maybe that can alleviate some of the stress or anxiety and having that conversation.
And I can start with other cancers. So definitely we'd like to. I mean, right now we're trialing the toolkit in multiple places to finesse it to get it to a good point. But we would like to trial it with other cancers. We do think it would be particularly beneficial. We'd love to see it with prostate. We'd also think, with parents of peds, it would be quite good. I think peer-to-peer with peds is a whole nother level that I'm not super comfortable with sending a toolkit out there. But I do think for parents of pediatric patients, it could be extremely beneficial. And then again, that's a caregiver level too, right? So it would be an interesting thing. And we've talked to a few people about that potential.
In Vietnam, beyond the peer-to-peer support for the women cancer, we also do some our Bright the Future Fund also to do some kind of the program to support for other cancer. We have also the support for the parents of the pediatric cancer, and we also have the program to support for the liver cancer and lung cancer. And we apply the toolkit and also apply the instrument from the peer-to-peer support.
Fantastic.
I just wanted to add,
Okay.
yes, I think, Cindy, you're absolutely right. We, in another study that I'm conducting, where we measured distress among caregivers, they actually have higher distress than the patients themselves. So there is definitely a need, I think, for this type of model to be provided among the caregivers. And we've also had interest from the healthcare workers in Vietnam, especially the nurses, in helping them manage and support the patients in the psychosocial needs of the patients that they're caring for.
Wonderful. I'm sorry, it feels like we could go on for another half an hour, but we do have to wrap up. And I'm just going to thank again our incredible speakers for a terrific presentation today. You've generated a lot of good thinking and discussion that we can carry forward, I'm sure, afterwards. So special thank you to all also for joining us. And don't forget to join us for our next session on June 5th, Tobacco Use Among Adolescents. And to register for a full slate of upcoming webinars, visit our events website and find more about upcoming events, global health news, and at our website, cancer.gov/global health. Follow us at #NCI Global, etc. on LinkedIn and connect with us there. All right. Thanks so much, everyone. Bye-bye now.
Thank you. Bye-bye.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.